Hello, it's Mark Kris from Memorial Sloan Kettering, speaking today about the truly amazing developments in the field of lung cancer, particularly adenocarcinoma and squamous carcinoma during 2024. And I'm entitling this piece, Good News for Patients, Better for Patients, Harder for Doctors. And the issue that has come up now is that with each piece of information that shows that a drug is useful, effective, there are often as many questions as there are benefits that have been presented, both in presentations and in papers. And I want to go over some of those today. I don't have all the answers in that how to advise you how to choose the best therapy, though I'll give you some suggestions as we go along. Let's first start with durvalumab in the perioperative setting. In June of this year, there were results of a large randomized trial giving durvalumab as an adjuvant treatment, patients completely resected in lung cancer. And there they found that in that trial, durvalumab did not meet the primary endpoint of progression-free survival when given adjuvantly. Just a month or so later, however, there was a FDA approval for perioperative durvalumab. And in that trial that was reported, durvalumab was given with chemotherapy prior to surgery and then for approximately a year after surgery. There was a clear benefit of the durvalumab containing arm in terms of disease-free survival, event-free survival, which was the primary endpoint of the study. In the discussions around these presentations and around the approval, it came up that the FDA raised important questions concerning the need for postoperative durvalumab and the degree of benefit of the postoperative durvalumab to the overall treatment regimen. As many of you know, there are trials giving only preoperative therapy that showed levels of benefit comparable to those giving perioperative, as the term has gone now, both adjuvant and neoadjuvant therapy. One, the issue is it necessary? And two, the issue whether or not you would be exposing people to toxicity inconvenience by giving a year of therapy. And the FDA has challenged people making trials now that designing trials rather, that they need to consider the components of each of the trial and to show the benefit of each component of the trial, the postoperative versus the preoperative. So what's a doctor to do here? Well, clearly there's no conclusive evidence that adjuvant durvalumab is a recommended treatment, and it's not undergoing any approval as far as I know anywhere on earth. But what about the perioperative setting? And I think there's significant questions there remaining. I think one thing you have to do, though, about neoadjuvant and or perioperative checkpoint inhibitor and chemotherapy is you have to look at all the data in that situation. And there has not been a single trial reported, not one, that says that preoperative durvalumab, or a preoperative checkpoint inhibitor rather, durvalumab included, with chemotherapy, did not improve event-free survival. And you really have to be impressed in this illness that every single trial has met that EFS endpoint. That is unheard of. There's also data from other diseases that neoadjuvant provides a better overall outcome than the same drugs giving adjuvantly and not given neoadjuvantly. So I think in the durvalumab perioperative trial, you have to go with the preponderance of the evidence there and say that perioperative durvalumab is an effective treatment, and we can recommend that for our patients. We're then, though, troubled by the issues that the FDA has raised, and that is how much better is that perioperative approach to a purely preoperative approach, and how are we going to decide that? There is no randomized data to allow us to do that, and that's a tough decision right now. Um, um, I think however, we do have a clear endpoint, rather a clear decision that we can use this regimen and other perioperative regimens as well. I think we're going to see a lot of research going on in the next many years in this space. Again, there's no randomized data that can tell you what to do. Um, and how are people approaching this? I think the first thing is for people that have benefit from neoadjuvant therapy, particularly pathologic complete remission, you really have to question about what is the role of the post surgical therapy. For people that have no benefit, clearly it makes no sense to continue those regimens post-operatively. And those would be people with less than a major pathologic response, in my opinion. But for those people in the middle that have some benefit but not a complete response, that's the toughest group right now. So I think we have an answer. If people don't benefit from the perioperative, you don't give it preoperative, rather, you don't give it after surgery. That have dramatic benefit, I think more and more people are recommending not adding it because already you have pathologic evidence that the cancer's been eradicated. That in-between group is a tough one. And that's a situation where I think the docs have to think long and hard how patients tolerated the medicine the first time, and also get their patients' opinion here, because we need to know what degree of extra risk they're willing to accept for an uncertain benefit. Again, it's better for patients. It's tougher for the oncologist.